just a huge honor. I can't believe I get the god of dentistry on. First, there was Pierre Fichard out of Paris. Then there was G.V. Black, and you are absolutely the heir apparent of both of those gentlemen. Gordon J. Christen, DDS, MSD, PhD. I don't need to read your bio, but I will in case you're some kid that was just born in a cave. Gordon Christen is founder and chief executive officer of Practical Clinical Courses, PCC, chief executive officer of Clinicians Report Foundation, CR, and a practicing prosthodontist in Provo, Utah. Gordon and his lovely wife, Dr. Rella Christensen, are co-founders of the nonprofit Clinicians Report Foundation, previously named CRA, which Rella directed for many years. Since 1976, they have conducted research in all areas of dentistry and published the findings to the profession in the well-known CRA Newsletter, now called Clinicians Report. Gordon's degrees include DDS from University of Southern Cal, MSD, University of Washington, PhD, University of Denver, and 2 honorary doctorates. Early in his career, Gordon helped initiate the University of Kentucky and University of Colorado dental schools and taught at the University of Washington. Currently, he is an adjunct professor at the University of Utah School of Dentistry. Gordon has presented thousands of hours of continuing education globally, made hundreds of educational videos used throughout the world, and published widely. Gordon and Rella's sons are both dentists. William is a prosthodontist, Michael is a general dentist, and their daughter Carlene is a teacher. He basically is a member of every numerous professional organization there is.
Too many.
If you can think of it, he's a member. I'll read a few. Gordon is a diplomat of the American Board of Prosthodontists, a fellow and diplomat in the International Congress of Oral Implantologists, a fellow in the Academy of Osseointegration, American College of Dentists, International College of Dentists, American College of Prosthodontists, Academy of General Dentistry, Royal College of Surgeons of England, and an associate fellow in the American Academy of Implant Dentistry. Some of his other memberships include American Academy of Aesthetic Dentistry, International Association of Dental Research, Academy of LDS Dentist, American Academy of Restorative Dentistry, American Academy of Fixed Prosthodontics, Academy of Operative Dentistry, and International College of Prosthodontics. Gordon, you are
too many.
Like I've told you several times, you know, I got out of school in '87 and I was kind of lost clinically, and I made 12. I figure since all the Muslims go to Mecca and Medina, I would go all the way to Provo, where every good dentist goes on their journey. I think I went up there 12 times, and you rocked my world. I mean, you rocked my world. And another dentist who went with me to all 12 was Mike Totola, and he still credits you for basically lighting his rocket. You could talk about anything. I want to start. This is Dentistry Uncensored, and I love you because you've never been politically correct. No one's ever owned you. You could throw any company you wanted to under a bridge, and they all knew it. So, Gordon, help me out on some of these decisions. I can take a 3M SP Impergum for $17 and send it to my lab.
Yeah.
3M also makes a scanner for $17,000. I just graduated from dental school an hour ago with $350,000 of student loan debts. Should I use the $17 3M Impergum or the 3M, what's their scanner called?
Okay, let's talk about digital scanners for a few minutes. 3M's not dumb, you know that. They make some of the best impression material on the earth, and they are extremely popular. They're either number 1 or number 2 in impression material sales. So why would they make a scanner? And they've had it now for several years. I've been in on a lot of the preliminary development of that just as a consultant, and they now have the lowest cost scanner. Let's just look for a minute at how you make a crown. There are 3 ways to make a crown, as everybody listening to this understands. You can do it the conventional way, where you prep, make a conventional impression, physically send the impression to the lab. The technician makes the crown, and you seat it on a later appointment. That would be right now, according to data from Glidewell, about 90% of the dentists who send impressions or digital into their huge lab, for which they do about 2 million crowns a year. That's a ton of crowns. So 10% are scanning and sending it in. And there you prep, you scan the impression, you send the impression to the lab by email, 1 click. The technician makes the crown. You seat the crown on a later date, or if the technician was close to you, you seat it on that day, which I think is really the future. I think eventually dentists, and there are 40% of them now who are who are either corporate or in a group practice, and that 40% are with somebody else. So why not have a little room somewhere, a 12 by 12 foot room with a milling machine in? You pump the button on Monday, I'll do it on Tuesday, and 20 minutes later you got the crown in your hand. That seems to be a logical thing. But we're seeing in that second alternative I just stated, the prep, scan the impression, and click it off to a lab, about 10% of the impressions coming into GlideWell, which represents every state in the union and most of the provinces and a lot of other countries. Then you got the third level, which you know well, and that is prep, scan the impression, and mill it in your own office. And that's only in approximately 10,000 dentists right now out of 141,000 general dentists. So that has not made a major impact over the 31 years it's been around. Now, what scanners, by the way, interrupt me anytime. What are the advantages of scanning? Since only 10% are doing it, there must not be an enormous amount, or 90% would be doing it now. When the air rotor came on, everybody had an air rotor in 6 months. This has been around now 31 years, and but it's been developing that long, and we have basically 10% of the dentists. What are the advantages? You got a really large monitor you're looking at, and that monitor allows you to see that tooth preparation in detail that you never dreamed possible. Otherwise, you're looking at something the size of the end of your little finger. And therefore, the preps are better. It's a pretty dumb dentist who sees a regular prep in a large image and does not make it better the next time. There's not as much gagging, barfing. There's no impression debris on the patient. They're just sitting there peacefully. The infection control is non-existent because you click it in 1 millisecond and it goes to the lab, so there are no bloody cotton rolls and big pieces of phlegm on the impression, which you see. We just did a survey on that. How many impressions are disinfected by dentists? And do you know what it was? It was pathetic, 23%. In other words, 70 some odd percent are going in with every kind of organism conceivable. This would eliminate that. There's immediate transfer to the laboratory by one computer click. The accuracy is better. And depending on the business model, it can be less expensive. Now, what's happening with these scanners at the moment? There's 6 that are the most popular. And I'm going to name those, and we'll go through them in a little bit of detail. The Trios last year, the 2016, in GlideWell data, which is the biggest lab in the country, that's why I use it as an example of the nation, GlideWell increased Trios 266% in 1 year. That had the most advancement last year. CareStream, 76%, Plan Mecca, or what's been called D4D, 70%, Cerac, 46%, 3M, 31%, and Itero, owned by K-Dent and Visalign, at about 22%. So all of those numbers are pretty impressive. And as you look at what has happened in the increase of scanner use, from 2012 to 2016, it's gone up. I'm approximating 600 or 700% since that time in those brief 4 years. Will it continue to go up? I think so, but I'm going to look at each one of these 6 devices with you in detail. They range from $17,000 to mid-40s, $46,000. $46,000 is a heck of a lot of impression material, as you would think. A full arch maxillary impression done with a premium material ranging around 60 cents a cc will be about a $40 impression in a stock tray. So all you got to do is divide $40 into $46,000 and you get some kind of an idea how many impressions you got to do. A typical general dentist does about 20 indirect units a month. And that's 240 in a year, but most of those are done with a double arch tray. 70% of them are done with a double arch tray. The double arch tray does not require $40 for the impression. It's more like $10. So again, if you're going to make that division, you see it's quite a few impressions. We're not doing it for money purposes. We're doing it for the advantages that I mentioned previously. Let's just look at the negative of all but one of the 6 scanners. That doesn't mean the 6th one is the best. It just says all of them have these 2 major disadvantages. And I'm sure any manufacturer listening to this would agree. The camera end of the scanner is way too big. I would like to see it, and so would everybody else, about the size of a pencil. If it were the size of a pencil, you would have no trouble getting it into the first molar, second molar area. A typical person can open their mouth about 3 of their own fingers, and that's about 40 millimeters. But as you go further backward, obviously you got a lot less space. And in a person who's arthritic or sclerodermic, they're not going to get that big mother camera in there real easily. So the camera is too big on every one of them. The smallest one is the 3M one, the true definition scanner. The other challenge with everything but the 3M is that they've got a huge pod on the rear end of them. And you tend to grasp these right about at the junction of the camera wand and the pod. And the pod will be, 4 or 5 centimeters in diameter, and the length will be, 7 or 8, I'm guessing on that. But it's a huge appendage hanging on the end of this camera, which you know well. Now, is that negative? Yeah, it is with a small hand. I have small hands. Most females have small hands. And when you grasp the camera, you have your fingers toward the end of this pod and camera affair. And that makes this pod weight it down on the wrong end. It's pulling the camera up from the teeth. As you look at these, all of them have this characteristic except 3M. How did 3M get around that? If they got around it, the rest should be able to get around it. But even their camera is about 2 to 3 times the size and diameter of a pencil. I would like to see it down to the size of a pencil. If we've got all these microchips and all this exotic computer armamentarium out there, why can't we get it smaller? For crying out loud, a Nikon camera, a Canon camera has very tiny, tiny micro chips in it, and the sensitivity of those. So every one of the major sales brands, Trios, Carestream, Planmeca Fit, Cerac, and iTero have the disadvantages. I'm not trying to be negative. I'm just saying we're about like automobiles in the, I'm going to guess, 1920s to 30s. In other words, they were, but how was the automobile then compared to where it is now? I see that same evolution going to have to take place before everybody leaps out and spends their $17,000 to $45,000. Now, the true definition, I've sounded very positive about that. Let's get a little negative for a minute. It had a cart until recently, and most dentists do not want a cart. Too many carts now. We've got a cart for a laser. We've got a cart for the new Sonendo gadget. We've got a cart for these gadgets. Soon we won't be able to get our fat rear end in the operatory and walk down the aisle. So most are liking to have some object either hanging from the ceiling or sitting on the left or the right. And now here's another advantage of 3M. Theirs is an iPad. And their current one, and that's only been a few months ago that they got rid of their cart at the suggestion of many of us, certainly including me. I've harped at them for 5 years on that cart business. And the ability to have a very small monitor is good. Well, it's like an iPad, so same size. Given that orientation, then, 3M is positive with this exception. It requires a slight amount of powder. And that powder, many feel quite negative about because conceptually they think back to the original Cerac, which was not a powder, it was like a snowstorm over the teeth. Now the slight amount of powder, it takes 5 to 10 seconds to put it on. It's an extremely thin layer, but because of the stigma on powder from many eons back, some are still negative about putting the powder on. And I suggest to any one of the observers of this podcast to look very seriously at going to a major meeting and perusing the booths of these, at least the 6 companies I've mentioned, which are the most popular ones, and looking at those cameras, using them on models that the companies all have present, and see which ones turn them on, which ones do not turn them on. I feel very strongly, as a matter of fact, that it's not going to be many months before the digital impression concept will take over. Here's essentially my suggestions. Restorations made from digital impressions are proven to be more accurate. We were the first ones to prove that than polyethers or vinyls. And patients prefer scanning. When asked, which do you prefer? You prefer the impression material or you prefer this non-objectionable stuff in your mouth? And they prefer the scanning. Negative, the devices are still exceedingly expensive. I'd like to see them all around $10,000 or less. Several years are required to make the return on investment of buying a digital impression device and spending all that money and comparing it to the amount of impression material they might have used. And in a positive realm, the cost of the device to make digital impressions is compensated by patient convenience, elimination of numerous steps in the laboratory procedure, and dentist satisfaction. I'll give us 5 to 10 years before most dentists, except those geezers ready to die, are going to have a scanner. That's basically where I am.
So impressions are 90%. Scan to lab is 10% at the labs, and chairside
Yeah.
is 10,000, 140. What do you think of what's your general summary of chairside E4D owned by Plan Mecca or CAD Cam owned by Cerac owned by Dentsply Sirona? I mean, a lot of kids are coming out of school and saying, "Okay, Gordon, you're a prosthodontist. Do I need to buy a $140,000 CAD Cam from E4D, Plan Mecca, or Dentsply Sirona to be a good dentist? Do you think I need to go that route?"
I'm extremely biased, Howard, because after 37,000 units, which is about what I've done myself over the years, that's what my senior tech tells me, I've had relatively few real problems. We know that the margins of milled restorations don't even come close to fitting as did restorations made of gold. And, well, we'll never get to that level because gold was malleable. You could burnish it down, finish it down. One of the first research projects I ever did, I was able to get gold margins, type 2 gold, properly quenched to 1 micron. The typical milled restoration at this point will range somewhere between 40 and 100 microns open. There is a significant difference there, though, in the cements. The cements of ages past were all soluble, where the cements today are relatively insoluble. So I'm not sure that marginal opening makes much difference. The anatomical characteristics of the restorations of today can make a pedestrian laboratory technician look pretty good because they don't have to have much dental anatomy knowledge. There's so many libraries now. You punch a button and it comes like a mysterious image out of the cloud. So it's going to make it much easier for laboratory technicians to make an adequate anatomical characteristic. But your question, do you need to do that to be a good dentist? And I'm very mixed. If I were a typical general dentist doing 90% single crowns, I would say no. As a prosthodontist doing many multiple crowns, it's even more of a no because it takes me quite a bit longer time to do this tooth, that tooth, that tooth, that tooth, or particularly to scan an entire arch and get the kind of patient cooperation without slobbering and licking and talking and going through while I'm doing the scanning. It will augment the average dentist's ability to make a good prep. It will augment their ability to have adequate, if not good, occlusion. But you take the stud dentist, the real boutiquer, and they will do better with conventional methods. There's a candid opinion.
Okay, switch from crown and bridge on natural teeth to crown and bridge on implants. What do my homies need to know on implant prosthodontics?
What's happening in implant prosthodontics? That area is really on the move. I have had the opportunity to work with the Zest company over the last while. With the all of you know that Zest is locator, and you're all using locators. However, one of the major advancements in recent months, frankly, has been the advent of the holeless, in other words, no holes, in a prosthesis for an edentulous case seated over implants. And that, if some of you have not heard of it, it's not been popularized heavily yet, is the F, standing for fixed, dash TX, in other words, standing for fixed treatment. What the heck is that? I have been doing surgical implant placement now for 31 years, and I have done many of the original Brandemark, all on, well, the original six. The all on six extended from mental frame and forward and from sinus forward. There were 6 implants placed, and there were cantilevers then about a half an inch long that were placed distal to the last implant. And that they generally replaced about 12 teeth instead of 14 teeth. I've done many of those, and I've now watched them for 20 and 30 years. They have been relatively successful. However, many patients have complained of inability to clean, foul breath, screws breaking, having to redo the resin part, the tooth part of the overall prosthesis, which is never advertised by the companies who promote these. It's as though you're going to get that tomorrow and you wear it to the funeral with you, when in fact you don't. If we were showing pictures in this podcast, I could show you what it looks like in about 7 to 10 years. About 7 to 10 years down the road, the resin teeth have worn down, and the prosthesis has probably been taken off at least 4 or 5 times. I like to take them off once per year. Well, let's go back to where we were. The locator FTX eliminates the holes in the teeth, the access holes for the screws. And that has been one of the most miserable and objectionable concepts of the whole procedure to me. Every year, get them in, take the plug out of the holes, find the cotton or plumber's tape, or by the way, there's a new material there coming from Taub called magic liquid that makes filling that internal portion of the hole excellent, because you can just pick it out. It's an attenuated soft resin. You just stick a little picker in there and pull it out. But you would have to take the cork out of the top, which is usually a class 2 composite resin. Then take out whatever you put the coronal to the screw, then find the screw. And very often the screw was stripped or was loosened, and you had to put a new screw in, which is $20 to $40. The patient was whining. They're sitting in the chair an hour, half hour to take the thing off. Another half hour as the laboratory cleaned it, and another bunch of screws and more composite in the holes. So what an objectionable, miserable thing. So now Zest with this FTX has no holes in it. And if you have not seen it, I'll just describe it. I mean, if the viewers have not seen it, undoubtedly you've seen it. This has no holes in the teeth, no holes in the denture base, and it has a locator-like attachment on it that has upwards of 20 pounds of retention for each one of the implants. You cannot push that hard. You can only push somewhere between 10 and 25 pounds with your fingers. Therefore, it's popped over one of those, and then you move forward, pop it over the next one, move forward, pop it over the next one, and then finally you get 4 to 6. I still don't like all on 4. I prefer all on 5 or 6. If you lose one out on all on 4, you're 20K in the hole. So then how do you get it off? If it's got 20 pounds of retention on each one of those, and you want to take it off in a year to see if everything's cool with the implants, to be able to clean the implants, be able to clean under the denture. How do you take it off? There's a hydraulic prosthesis lifter that looks like a balloon, a very tough piece of flexible plastic that's placed under the pontic areas on each side, one at a time, one pontic, one side at a time. And then you put some liquid in a hydraulic pump and pump, and that bladder inflates and pops the one side off. Then you go to the other side, because you can't take it all off at once, and pop it off. Now within, 2 minutes, you've taken the prosthesis off. The little balls that go down into the female part of the implant have been destroyed when you take it off, so therefore there's about a $70 charge to get some new balls to put on the male portion of the prosthesis. And you have now satisfied a significant challenge in the past. I really objected to taking the screws out and replacing all of the prosthesis portion that went with it. That's one of the major jumps. And since they're hyping all on four so strongly now, I'm frankly a little negative. But there are some advantages to removable. And I think any dentist who's doing this kind of dentistry knows what those advantages are. Well, let me give you the advantages of the Locator FTX. There are no prosthetic screws. There's no cement. The angulation correction is 20 degrees times 2 because it moves both directions. It's a stress-free and passive fit. It's a very good solution for immediate function cases if somebody's trying to do all on one day, which again I disagree with, but that's my bias. I prefer to see a remote ridge where I can trust it, and it's removable by a dental professional. It doesn't have to be a dentist. It can be a hygienist. It can be an assistant. It can be anybody who's trained to do this. So I see some advantages to being able to do this without a problem. There are some advantages, however, to removable over an edentulous case. Let's go there, because that is about 4 to 5 times less expensive than screwing it down. If you screw it down, you're into 20 to 30,000, depending on the ego of the dentist, per arch. If you put, say, 4 implants in, and now I would agree with 4, because if one fails on removable, what is it? Put another implant in, let it heal for a few months, and attach it to the already present denture. It's not a total redo. Let's say you put 4 implants in. And you put standard locators or ERAs or even spheres, balls. By the way, there's a new sphere orientation from Sterngold that everybody listening to this should know. You may tell them whatever brand of implant you're using and what diameter it is, and then what length of a collar you want on the abutment, and they will send you return mail whatever it was you requested. Let's say the implant is 1 millimeter under the gingiva. You wanted to stick 1 millimeter above the gingiva. You tell them you want a 2 millimeter collar with a ball on it. And if the bone is only moderate rigidity, I would strongly prefer the balls to the more rigid attachments. A little rubber washer can be replaced for $1. And you could do that every 6 months to 18 months, depending on how vigorously they chew. What are the advantages of doing it that way? Well, cost is number one, because a typical American family making somewhere between $50,000 and $55,000 a year can't afford a $20,000 to $30,000 fixed, but they can afford a $5,000 or $6,000 or one, which would be all on 2. Removable. All on 4 goes about $10,000. So a significant difference in cost. They can take it out, clean it, They can have much better facial form because you don't have to relieve it significantly to allow them to put a pipe cleaner or a water picker or whatever under it. So the facial form is full. They have the ability, if it breaks, to have it repaired in, well, half hour, and it's back in their mouth. And if an implant fails, you can add an implant by just putting it in, letting it heal, and attaching it to the base. That's probably the newest thing in the more complex implant-supported prostheses. The secondary thing that has been extremely, I think, paradigm changing is not using abutments that you screw on and then cementing over them. And you know as well as I, the screw comes loose on those abutments fairly often. As it comes loose, there's another pain in the rear. It's usually 5 o'clock right before a meeting you're going to, and they come in and say it's a little bit loose, and now you've got to figure out that the dude who put the implant crown on that do it with provisional cement, final cement. Did they fill the hole down into the screw, or did they leave some cotton or gutta percha or something in it? So you never know. And you try to whomp it off, you break the crown, you know all the problems. So right now, I would say candidly that if the implant is near perpendicular to the occlusal plane, the standard of care ought to be screwing through the crown, not making an abutment and attaching it to the abutment. Pretty obviously, that eliminates the cement problem. It provides, when it does come loose, and I did a survey of the American Academy of Aesthetic Dentistry recently, and I had them guess how many percentage-wise of crowns cemented over abutments have come loose in their career. And I got a very well, it's totally empirical. I got a number of around 15%. That means out of every 100 crowns you cemented, about 15 of them you're in this miserable situation with. So I would caution dentists to get away from abutments when, as I said before, the implant is near perpendicular to the occlusal plane. If it's sticking facial, and unfortunately, I still see a lot of those. I deal with quite a few surgical specialists, and some still have not figured out that we want them to be perpendicular to the occlusal plane if they possibly can be. So they're sticking out at various odd angles, as high as 45 degrees. I had one just recently almost parallel with the occlusal plane, sticking out like a coat hanger. Unbelievable. So screwing through, let's say it comes loose and you've screwed through the crown. What do you do now? You pop out the cork on the top and you find whatever's down the screw hole, you take it out, you take the screw out, you clean the hole out with whatever, phosphoric acid, Ivoclean. If it's zirconia, you can't use phosphoric acid, but Ivoclean works. If it's not zirconia at all, I would use phosphoric acid under, wash it out, put a new screw in, torque it to 30 to 35 Newton centimeters, and recork it, send them home.
This is Dentistry Uncensored, and I like to talk about the controversial things. One of the biggest controversial things in implant dentistry is to use a surgical guide or not to use a surgical guide.
Oh, wow. Yes, very, very true. I made a video, by the way, a little hype for our educational programs. If listeners were to go to the website, very simple, P like Paul, C like Charlie, pccdental.com, you would see innumerable educational possibilities for you. Among them, are many, many videos. We change videos as soon as they're out of date. We change courses. Every course I give, half of it's new every time I give it.
And I just want to say one thing about your websites. What I do for my guests, because my guests
Yes.
are listening right now, they're driving to work. So I read those two websites you gave. I just retweeted your CR Foundation. So if you follow at Howard Ferran, about 20,000 do. I just retweeted your at CR_foundation, and that has a link to your clinician's report. And then I retweeted Gordon Christian, which is at GoJChristian, and that has the website. So if you're trying to work, don't worry, just go see my last 2 tweets, and the last 3 were all Gordon's tweets.
You and Trump are tweeting all the time. Yep. Did you learn that from him?
No, what I like about Twitter is Facebook. When you post something on Facebook, it doesn't go to everyone who likes your page.
Yeah.
But Twitter, if you build up 20,000 Twitter followers, you make a tweet, all 20,000 get it. So Facebook says, well, build up this huge following, and then when you make a post, if you want everyone that follows you to see it, give us money and boost your post to all your members.
Oh, yeah, I agree.
I still don't know how Twitter makes any money because I've never given them $1 in my life.
Yes.
How do they stay in business? I've never given them a dime.
I have no idea. I think they're selling marijuana and cocaine on the side. I think that's probably what it is. Hey, by the way, let's go back to this guided versus non-guided. Now, if we go back 30 plus years when root form implants were introduced by Brannemark, out came his original all on 6 orientation, and everything was hooked together. In other words, some of them even put a bar across connecting the 6 implants together. There was no anti-rotational feature. There was nothing there, and it was all by guess and by golly. You felt it with your fingers. You palpated it. You used ridge calipers. And by the way, there's something that your listeners really need to know. Numerous companies make ridge calipers. That's where it's like a ice pick. You put the thing on the ridge and go facial lingual, facial lingual, facial lingual, facial lingual, moving up. And you find out, ooh, I've got 8 millimeters there, but there's 1 millimeter gums on the front, 1 millimeter on the back. That means I really got 6, and that's enough to put a 4 millimeter diameter implant in. So that was done routinely way back. And that was the only way we had of judging. Subsequently, about 20 years ago, on came tomographic radiographs. I did those for years with instrumentarium. That's where you're putting in 2 implants, 1 in each canine area. You do 1 image and 1 image. That was great. That was all I really needed. I don't need 750,000 slices of the head to know where I'm going. But that satisfied me for about 15 years. I've had cone beam now 17 years. And I don't know how I got along without it. In fact, that's another thing we may want to talk about in a minute. But the question is, how many of those thousands, millions of implants were placed freehand? And the answer is, I don't have the answer. The answer is more than 95% of us placed implants freehand. Now, I teach 3 implant courses in our course series. The first course is simple single implants in healthy people with good bone. What's good bone? Good bone would be 6 millimeters facial lingual. It would be upwards of 10 millimeters in incisal or coronal apical. And if they've got that, any village idiot ought to be able to put an implant in. I think you would agree with me on that. Now, the second course gets into socket grafting, it gets into sinus lift and some of the stuff that the many dentists do not want to do. They would rather refer those. And the third one is, how do you restore all these things? So we've got 3 levels of courses, and I've had a hard time teaching, not knowing whether to teach guided first, which is all the hype now, or whether to teach freehand first. So I called a significant number of so-called implant specialists. You would know every name if I were to mention them to you. And I said, okay, what would you suggest if you were deciding in your elementary course, you're going to teach freehand or are you going to teach guided? And what do you think? Give me your opinion. Because there isn't a right opinion. What do you feel, Howard?
Well, I mean, every single person I know that's placed over 1,000 or 5,000 or 10,000 never used a surgical guide. And, you got most of them replacing the first molar. I mean, when you look at the insurance data and you print out 1 to 32 teeth, it's the 6-year molars where you just got 4 huge spikes for root canals, crowns, and implants. and you got a second bicuspid in front of it, you got a second molar behind it. You can put their head right in your
Right.
lap, and you need to be a surgeon because if something goes wrong with that surgical guided where you're punching through the tissue, you need to learn how to be a surgeon. You need to know how to lay a flap,
Yeah,
check
yeah.
out the bone, repair. I mean, it just if you're going to be an implantologist and you're going to use guides and just punch through the tissue, I don't think you're ever going to be an implant surgeon.
Well, you agree with me completely, and with the majority of the people that I call. There is the fairly logical question, would a real neophyte who's even afraid of blood, well, they probably ought to not be doing implants anyway, but take that person who's really not done a lot of surgery, not extracted a lot of teeth, and all of a sudden they want to screw in the bone. That person is going to trust the guide. Can we trust the guide? If I'm putting an implant between a canine and a central incisor. We have a lot of those in Utah. It's congenital defect, as you know, and usually they've had some orthodontic treatment to make a little more space, and often they tip the teeth this way instead of moving them bodily. So I will end up with an average of 5 millimeters between central incisor and canine, 5 millimeters. I need 6 to really be comfortable. There's plenty of bone up to the nose holes, and you can even perf the floor of the nose if you want to. But let's say I got 5 millimeters. Can I spare 1 millimeter, which is the average inaccuracy of a guide? No way. No way. In fact, I did a video a while ago, which got me talking about videos. I did a video a while ago where I picked a case like that, one missing here, laterals, and I did guided on one side and freehand on the other. And recorded every step of both procedures. So it's pretty interesting because pretty obvious that guided on one has to cost the patient significantly more because I've got to send in a cast or a scan, and the implant. One of the companies we use is Implant Concierge in Dallas. And they're telling me only about 10% of their casts come in scanned. In other words, 90% are sending an inaccurate Alzheimer's impression poured in an expanding stone. You following all that? And expecting that to be accurate. Good luck. Even a scan will be slightly inaccurate for a full arch, but the typical scan, much of the research shows is off at least 1 millimeter with the guide. And the drill for a guided placement is 25 millimeters long or more, where the drill that you're using standard for an implant would be half that. So how about that long lever arm? You're starting to drill the hole, and if the lever arm is off even slightly, the tip of the the drill is way off. So I did that video, and it was really very interesting. To do it guided, I have to get on the phone, talk to the company. They then send me a prototype of 3 or 4 different alternatives. I correct one of those, and they send me the guide. And so if I'm doing a rehab and I got to jerk a tooth and put an implant in that day, I can't do that. There are quite a few disadvantages. If I wanted to, on the lateral incisor, if I want to go in and make an incision and push the soft tissue forward, it makes it a lot harder when I'm doing guided. Or when I'm doing unguided, make the slit lingual, move it forward, put a typical temporary restoration on it, and create papilla. I see right now, after thousands of implants that I've placed, there's a secret. Here's a tooth. Here's a tooth. Go down the middle. There's the secret. Put your fingers on the facial and lingual when you're starting the drill. If the drill has vibration toward the facial, move lingual. If the drill has vibration toward the lingual, which it won't usually, there's the palate there, then you would go facial. So what was my decision in the elementary course? Do freehand, because they learn more freehand. Then when they're starting to do multiples, 3 or 4 or 5 in a row, that's another story to help you with the parallelism. But even that, I can put one in, put a paralleling pin in it, parallel it with the next one, the next one, the next one, the next one. It's a moot point. But with the 90 some odd % having been done freehand, It's like trying to tell somebody they need some guidance to drive their car now, or after they've driven a car a million miles. I'm obviously biased. I fully admit it.
I try to, I try to help them. I always do a transcript of the podcast, so they're driving to work. All this will be on the transcript. Are we up to date on all the transcripts? That's good. And you mentioned Implant Concierge, so I just retweeted that for him.
Okay.
Implant
That's it.
Concierge, for everyone who's never heard of it, doesn't know anybody. Who's the CEO of that?
Implant concierge.
Yeah.
I don't know. I
But
don't
but
know
why
who's the
why do
CEO.
you use Implant Concierge? What is it, and what do they do for you?
Oh, okay. Implant Concierge is one of many, many labs that will make a guided, printed guide for you. And a lot of dentists, in fact, our next big research project next year, going to take a good bit of the year, is to try to get printing into dental offices. And I don't mean printing paper, which some dentists still feel what printing is. I ask often in a course, you got a printer? All the hands go up. They're thinking of a paper printer. I'm talking about a printer for occlusal splints, guided placement, the whole business. Implant Concierge is one of many. The reason we use that is because one of the brands we use quite often is Implant Direct, which, as you remember, Implant Direct for in the $200 range has the implant, the cover screw, the abutment, the transfer coping, whereas you can pay $700 to some of the other companies for the same group of pieces.
We just podcasted the founder of that, Jerry Nisnik, a couple weeks ago. It was a great podcast.
Yes.
He was a mover and shaker in implant dentistry, wasn't he?
Oh, no question. I've worked with him ever since we were both in puberty. Yeah. Yeah, I know.
The funniest thing he said, I didn't want to laugh because I just loved Carl Misch, but whenever he didn't like anything Carl Misch would say, he always says, yeah, Carl keeps spreading misinformation.
Misinformation. Well, we all had a lot of respect for Carl. I'm sorry he's in the grave right now. We're all going there shortly. It's a great opportunity to help people with implants. As I look back over my career, there are several things that stick out very strongly as being highly prominent. One is the air rotor, of course, and everybody had it, as I said earlier, within 6 months. As implants came on, it frightened dentists. But one thing a lot of general dentists don't understand, the whole root form implant concept and blades and Ramus frames, the whole business originated not with surgeons. It originated with general dentists. The Alabama Implant Dental Study Club, people like Hilt Tatum and many others who were general dentists. Hilt Tatum looked like an oral surgeon because he was a general dentist turned oral surgeon. But in the meantime, a lot of general dentists think, oh, this is way too hard. I have to be a surgeon to do this. Well, our grandparents are general dentists. They're not surgeons.
What happened to Hill Tatum? He was in Florida forever. Then I guess he packed up, went to Europe. What did he do? Find some little hottie?
By clear chance, I sat by him on an airplane recently, and I've got sitting right by my side a bunch of little ridge splitters that he gave me. He's older in the hills. He's older than I am, and that's really old. And he's still there. He's still doing surgery.
Do you have his email or anything? He's one of the legends. I want to podcast him so bad.
You should. He was one of the real movers and shakers in implant dentistry.
You remember how he used to teach sinus lifts?
Yeah.
With an egg.
I know.
You would perforate the egg, and oh my God, he was just a legend. Where did he move to? France?
Yeah, France. Hilt Tatum. I'm just looking him up right now. Here it is. You ready?
Yeah.
HILT, then another T, TATUM at yahoo.com. I'll repeat it. Hilt, his name, Tatum, all together, no dot there. Hilt Tatum at yahoo.com.
Huh. Yeah, just amazing. Where was he at? It was St. Petersburg, Florida. Was that where he was at forever?
Yeah, he was with Dawson for a while.
Yeah, that guy's amazing. Okay, I know I don't got you for very much time because you got to run. But next week, 6,000 kids are going to graduate from dental school. Another big, they got a lot of student loan debt, and there's a lot of high price equipment. What's your views on lasers?
On lasers, I have been using lasers for 50 years. The first one I used was big as a car. We were trying to fuse.
It was
calcium
$50,000. I bought it too. That was an expensive toy.
we were trying to fuse calcium carbonate onto tooth surfaces to seal the grooves. I mean, it seemed logical to me. We melted the calcium carbonate. Fortunately, it was extracted teeth because all the enamel blew off. And that was my first adventure. And subsequently, I've had many, many, many encounters with lasers. There are some 20,000 of them in the U.S. right now, give or take. And many of them have been made by one of our ex-employees. There's a guy out of PodCam, and that's Denson Chow, C-A-O. And he's an engineer, now has hundreds of employees in China, and he's made most of the lasers in America.
Can you email me and him, Howard at dentaltown.com, and then him, and introduce us to come on the show?
I'll give you his address. And most of them are diodes. Of the 20,000, I'm sure that Denson can give you better information than I can on the quantity right now. But Denson, I'm going to guess.
D-E-N-S-O-N?
D-E-N-S-E-N.
S-E-N.
D-E-N-S-E-N.
And then Chow is?
C-A-O.
C-H-O?
Denson, C-A-O.
Oh, C-A-O, okay.
Yeah, okay. Now, this particular orientation of diode is basically in the 800, 900 nanometer range, and it basically is light going through at that wavelength through a fiber optic bundle, and the light will do nothing until you put, as you know, a black piece of burnt cork or articulating color on the tip. So if you send light through this fiber optic bundle and it hits this black thing, what would it turn to? Heat. The diode laser is basically a large electrosurgery, a slow, large electrosurgery, making a cut, give or take 3/4 of a millimeter to a millimeter wide. Other lasers, not diode, but let's take CO2 as an example. One of the very significant brands that's now in that range for soft tissue only is called Light Scalpel, and it's in Seattle. I'm going to be off a little bit, $25,000 to $35,000, and that will cut a half millimeter, a 1/4 of a millimeter. Looks like a cold steel blade cut. That's a CO2 with a fiber optic bundle. Light does in fact cut. It's not just some large electrosurgery thing. There are 3 lasers now, 3 brand names that will cut hard tissue, undoubtedly more, but there are 3 well-known ones, Photona and Biolase and Solia. We're just testing the Solia the last 1 year, and this is a CO2 laser that surprisingly quite well cuts tooth. I have usually been quite frustrated with the length of time it takes to cut a tooth structure, but just recently on pigs in one of our courses, I was able to take the Solia laser and make incisions to lay a flap in seconds, and then change the setting and trim bone to do a crown lengthening, and then change the setting and cut a class 5 prep, all with the same laser with different settings. In about, I'd say that whole thing was 3 or 4 minutes. So it's really changed. I can remember when we first were doing cutting of tooth structure with lasers, my gosh, it was just a joke. Now it's starting to look like it is somewhat viable. It doesn't cut a prep, it cuts a hole. You're used to a prep that would be relatively smooth, that would have a distinct cable surface margin, identifiable easily, and now it looks like a porcupine when you cut it, as you know, with a laser. There are little spicules sticking out everywhere. There's no way absolutely no way the restoration can fall out because there's so many irregularities. We've looked very seriously at what happens to the melted enamel, which is what it looks like around the margins or on the class 2 adjacent surface of the tooth adjacent to a class 2. And Rella, my wife, did some evaluation there electron microscopically and found we could bond to that just as well as we bond to enamel prisms. And maybe, I don't know this, maybe it's even more caries resistant to have that enamel all fused together. I don't know that, but it's an interesting question. At this point, should a dentist have a laser or not? Like I said, there are only some 20,000 out of 141,000 general dentists. Should everybody have a laser?
So twice as many dentists have a laser than a CAD cam.
Yeah, yeah. CAD cam, they're about, they're 15,000 devices. I'm going to be off a little bit, but many of them aren't being used. As you know, you go to eBay or Dentaltown or somewhere, and you're going to find some for sale. So some have got one and decided, I love it. And they become a zealot, and they join all the clubs, and they become one of the boys or girls. And then there are others who got it and thought, for crying out loud, I did a conventional technique faster. So you've got both ends of that spectrum. That's why in 30 years it has not captured everybody. It's captured some, as you know. Many dentists hate lab work, you know that, and others like lab work. But back to the laser. The laser, yes, I think a typical general dentist needs a laser and an electrosurgery. The electrosurgery cuts up to 10 times faster. It'll cut a narrower cut. It heals faster. This is all contrary to the hype. It heals faster in our dog studies. It leaves less scarring than a laser. Basically, it's over the healing period can be even more painless because you've barbecued all the nerves when you cut it with it. I'm not negative about laser. Here's the major positive thing. It has less heat. That's another bad thing in the hype. The heat created by an electrosurgery is more than a laser. But some of the hype for lasers says you don't have any heat. The heck you don't. We put thermocouples in meat and tested the heat produced by a laser compared to the heat produced by electrosurgery. Obviously, the electrosurgery creates more. And the electrosurgery, if you hit metal, here's another very good advantage of laser. With most lasers, you hit a porcelain fusion metal crown, an amalgam, anything that's metal, a bar, and you got sparks flying, the hair sticking straight up. If you hit it with a laser, big deal. Not much happens. So there is this singular major advantage of the laser. Well, I won't say that. There's another major advantage, but it's not biologic, it's psychologic. If laser is good for eyeballs, it must be good for teeth. That's a patient conception. And you know, everywhere you go, there's some laser ad for vision. So we're riding kind of on that crest with laser. If laser was really I'm going to be kind of negative right now. If laser was really as important as some think, everybody'd have one. So why do only whatever 1 out of 6 have one, 1 out of 5 or 6? It's obvious. There are other ways to go.
When you mentioned hard tissue, you said Photona, Violace, and Solea. But
yeah.
what AMD, Allen Miller Dental Lasers, just came out with their light touch. You didn't include light touch. Why was that?
Only because we haven't evaluated it yet. Yeah, okay. we get on it. Yeah.
Have you
By
met
the way,
Allen?
last year we evaluated a little over 700 new products. And
oh my gosh!
And your listeners won't want to hear this, but only 1 out of 5 met their claims. 1 out of 5 of the 700 plus met their claims, and we see it every day. I'm in these research labs.
How much more time did I get you? Because you told me I had to go an hour. It's exactly 1 hour. How
Oh,
long can I hold you for the
Yep,
chair before you have
let's
to
go
run
another
for your
10
car?
minutes. I can still make it. Give me another 10 minutes, okay?
10 minutes. You're so sweet.
Yeah.
Tell me if this is true or false. Since you and I have been, when we got out of dental school, there weren't cell phones. I mean, first we had
No,
the little Motorola flip phone, then the Nokia and iPhone. Is it, some people think, why would I want to buy $100,000 CBCT cone beam technology when in 5 years the new one's going to be twice as nice? I mean, if you told me I had to have my same smartphone for the rest of my life, I'd be sad. I'd rather rent it or lease it. So is that true or false? Is mine a CBCT gonna be last as long as your iPhone before it's outdated, or is that not true?
you are really on a good point. There are three major areas in dentistry that will drive most dentists to cone beam. And I've been on, as I said, 17 years. I started with Plan Mecca, and we've now evaluated a half dozen brands. I originally bought the Plan Mecca piecemeal, not even knowing if this concept would turn into anything, which it definitely has. Endo is the main thing that's going to drive people to cone beam. Why? Because let's say a general dentist or anybody does an endo, it looks perfect. This actually happened to my son in Canada, who practices up there.
Mikey,
Yeah, Mikey boy.
Mikey
Uh,
the hunter.
Mike will do everything from brain surgery to circumcision. He doesn't resist anything as a general dentist. They drag bodies up on his porch in the middle of the winter. Of course, it's 40 below, and he's supposed to identify them by their teeth. It's an interesting kind of practice. But anyway, with the cone beam, let's say somebody does a root canal, looks perfect. It's a three-rooter. It looks like it's a three-rooter. And they get upset because it's still painting. They hear about endodontists, which most people don't even know the word. They go to an endodontist. The endodontist got a cone beam, and John West and I, he created a survey, and I assisted him a little bit. John West, being a well-known endodontist in Washington, did a survey, and about 70% of endodontists have now got a cone beam, and that's only a couple of percent of general dentists. So they go down the street, they find an endodontist. The endodontist does a cone beam, and lo and behold, there's another root. And usually it's disguised by the fact there are three there, and there's one right behind it, and you can't see it at all. You flip it 90 degrees, and it's obvious there's another root there. There's a lawsuit just waiting to happen, and there are now lawsuits about endo. Endo being semi-witchcraft. 20% of endo, according to certain surveys, one out of New York U, are failing in some way by just a few years. The patient still knows something screwed up with that tooth. Our recent survey, which is empirical, granted, it was about 1,000 dentists, said about 10% of their endo is in some way failing. It's either the patient knows that there's something wrong with the tooth, or it's literally failed by 5 years. So that area of dentistry done by typical general dentists we just finished a survey on it. The general dentist is doing between 0 and 4 endos per week. However, some will do as high as 20, but the average was very low. I was surprised. As you know, the net revenue of a dentist is the major portion is fixed pros, but the second portion in volume is endo. So they ought to be looking seriously at finding access to cone beam for legal purposes as well as physiologic purposes. The next one that's going to demand it, it's already demanded it for me. I had half my implant career without cone beam. I look back and I could have killed a dozen people, because I'm now seeing things I never seen before. So implants, if they're doing implants, they need to either buy one or go in with another dentist and share one, or find a radiographic lab in their community who can do the radiographs for them and hopefully help them until they learn how to do it. We have we have a cone beam course right here. In fact, we've got one coming up in a couple of weeks where I use Dale Miles, oral and maxillofacial radiologist, and me, and we we actually do cone beams on some of the participants and let them see in their own head. They're a lot more attentive when it's their head than some
So
phantom head.
if you were an endodontist or a general dentist, would you want a different brand of CBCT than say you're an orthodontist who wanted,
Yeah,
both jaws
yeah.
and a ceph?
Right now, the major brands, the major brand right now is Sirona, and that's because of the CEREC interaction that you know. The second the most major brand is the ICAT from Nine, and the third
Who
most
makes ICAT?
popular
Is that
is
ITero?
ICAT, ICAT.
Is that made
ICAT.
by ITero or is ITero completely
No,
different?
no, it isn't. And then the third most popular is the Planmeca, which is the grandfather of the whole gang. Early on, all of those were in the $150,000 range. Now we've got quite a few coming on that are in the $60,000 range, and that's where I suggest general dentists go. They should be looking at brands like CareStream, the 8100 model, which is around, I'm going to be off somewhat, mid 60s. And another one that's going to really make a significant impact in America is Vatek, coming from South Korea. And just like Hyundai and Kia and those automobiles have made such an impact now, it seems like every third or fourth car I see is a Hyundai or a Kia. Similarly, their Vatek brand, which is the most popular one in the world, but not in America because they just came in here, they're in the mid 60s. There are two brands, a person who's a general dentist and interested in limited field. If I'm doing 6 teeth, I don't need the whole head, I just need that. And therefore, you're only responsible legally for that. You're not responsible for the whole head. If you do the whole head, you're responsible for the head. If there's a tumor in there you missed, you can be sued on that very nicely. I do see cone beam right now, access to cone beam. When you ask me, do they need to get it, I'd say no, but they need access to it. And so, since so few have found access to it, in my observation in courses, I would say I'm seeing 30% with access to cone beam.
Okay, I only got you for 3 more minutes, so I got to have you rant on the
Okay.
3 most topical areas I see calling crazy. Sealants. I mean, Gordon, it seems like all the research says half fail in the first year, half fail in the second year.
Yeah.
And a lot of people say, no, that's not true. Rant on sealants. I mean, how long does a sealant
I
last?
will. Rella, my wife, has done obviously microbiologist and physiologist. She's done a lot of research on that way back, and she continues to do it on caries. In about a year, she'll blow the whole caries theories apart. Most of the things you and I learned in dental school, and even currently, comes from the 1800s. W.D. Miller and others theorized and did some micro. Now we're doing not only micro, we're doing DNA analysis on it. We're identifying genus and species on the organisms in caries, and we're finding organisms that are not even in textbooks, that have never been identified. And they're different as you go down inside the tooth. We need to disinfect the miserable cavity preps, because what we're calling recurrent caries is really continuing caries. It has nothing to do with recurrent. It continues if you don't kill the bugs. And we've been promoting now for some time the use of the glutaraldehyde-containing solutions, 2 minutes of which, 2 1-minute applications will literally kill everything to the pulp. And that would be Gluma, or one of the more popular, less expensive brands, Micro Prime from Danville. But you probably know Danville was just bought out by Zest, and a lot of their products are absolutely excellent. But back to your question. Yes, sealants are falling off. The international data says about 50% within 5 years. And a lot of the dentists are using old products from the literally 60s that were partially filled. They ought to be going into products like Filtech Supreme Ultra Flowable. Filtech Supreme Ultra is well known. The Flowable is not as well known. And that wears about the same as Filtech Supreme, the Ultra, the restorative product. They should get off these partially filled things that have been around forever. They should also be using a air slurry polisher, which only not even 20% of dentists have because it's such a freaking mess. But if they would use an air slurry polisher to clean out the plaque out of the grooves, there's no reason for a sealant to fall off, won't come off. If they leave the plaque in there, most hygienists will just scratch the occlusal surface with an Explorer thinking they cleaned the plaque out.
What air slurry polisher do you like?
Profijet, Cabajet, either one of those from Dentsply are the most popular brands by far.
Profijet or what?
Cabajet, Cabajet or Profijet.
Is it I use the one from Danville, the Danville micro.
Danville's fine. Danville's fine. Yeah, yeah.
Cheap as heck too.
Yeah.
Another question. You know, amalgams last forever because when they set up, they expanded. The seal, the corrosion, the seal was incredible.
If they kill teeth, they kill teeth. Yeah.
All composites shrink.
Right.
But now there's a move, instead of putting in a layer cure, a layer cure, a layer cure, now it's bulk fill. Do you think that's a good idea or a bad idea? Which composite's going to be lasting longer? Incremental cures or a bulk fill?
I just published a paper on that, or will publish. It's in the press right now. It'll come out in Dental Economics shortly. Basically, right now, what we're seeing is the materials for bulk fill are excellent. Sonic fill, wonderful material. It turned out to be very high in our evaluations. However, the way some of these are being used is really defective. If you aim the light, here's the surface of the resin. If you aim the light even 15 degrees from perpendicular, Tim Palmer, our physicist, says 80% of the energy is lost. And you're going down a 9mm box form, you're 15 degrees off. Oh, sheesh. The box form, the depth of that is jello. And we're seeing far more class 2 caries now that they stick 4 pounds in and try to cure through it. It doesn't work. If they're going to do bulk fill, they ought to be doing their prep, doing their normal bonding, going in and putting in the most apical part of that, about a 0.5 millimeter of resin, curing that, and then put a large wad in. I still do incremental cure, and so do most people doing research. It's just too hard to get the light aimed correctly and get it down that far with adequacy. Even though they think I can put the Explorer on and it's hard, it may be hard, but that's it. It can be hard at 40% conversion. We need 60% conversion to make it adequate over the long term.
Final question, because I know you got to run. Final question.
Yeah.
Huge controversy, especially around the world, of what lasts longer, an amalgam or a direct resin?
I can say it in one sentence. Amalgam lasts twice as long as composite.
So if it was do you have any grandchildren yet?
Yeah, I got great grandchildren.
So if your 6-year-old grandson needs an occlusal on a 6-year molar, he's a boy. No one will ever see it. I've been talking to you for an hour. I've only seen your front bicuspid to bicuspid. I have not seen your molar the whole time. Would you go with an occlusal amalgam or occlusal direct composite?
This is going to sound really biased. People want white. You know it. But white's being done really poorly in America. The average big composite lasts 6 to 7 years, according to international data. The average small composite in our research goes 15 years. I would want a well-done composite by a meticulous dentist. It would be white, but on the other hand, if the dentist is hungover or a pedestrian level of quality, the amalgam would be better. Period.
But Gordon, you know how many times I've been in a very poor third world country, and I'm in the dental office, and they're watching the Americans, and they're trying to do bonding, and they'll acid etch, and then they'll rinse with a Dixie cup and a pickle bucket. Then he'll paint on the bonding agent and cure, and then the lady will sit up and rinse. And then he'll put in an element of composite and cure. Then she'll sit up and rinse and spit in a bucket. And you look at these techniques around the world, and I don't, there's 2 million dentists. 1 million of them don't have the facility to even do. a direct resident.
No. Yeah, they ought to be putting amalgam in with absolutely no reservation in my mind.
All right.
Yeah.
Thanks, man.
Hey, good to talk to you.
Good to talk to you. And any legends that you think should come on the show, just tell them to email me. I respect
Thank you.
anybody
I
you
will.
send me. Okay.
I'll get you some names.
Okay,
Thank
buddy.
you.